Okay, so this is a very hyper-focused, no-nonsense review to help you get across the line in the exam. So let's get right into it. So tell me the symptoms of primary syphilis. Usually a single, painless ulcer with a clean base and firm edges at the genital organs. Okay, and then how do you diagnose it? You start with VDRL and you confirm with the FDA antibodies. Okay, and then how do you treat it? Benzathine penicillin G IM single shot. Okay, can you tell me the symptoms of secondary syphilis? So a rash, okay, that involves palms and soles, so little red dots on palms and soles, okay, condyloma lata, okay, and then it can also have mucocutaneous involvement. So look for moth-eaten alopecia appearance or uveitis, okay. Secondary syphilis can also cause hepatitis and generalized lymphadenopathy. Diagnosis, again, VDRL and confirm with FDA antibodies, okay? And treatment, again, benzathine, penicillin G, IM, one shot, okay? You must also know that super early primary syphilis can be seronegative. So even though you have the classic chancre, the antibodies can be negative early in the disease, okay? So in that case, you have to do like a microscopic examination for Troponema pallidum. So that's how you diagnose in seronegative primary syphilis if there is a clinical suspicion, okay? What if a patient who is totally asymptomatic, does not have any symptoms of syphilis, and their VDRL and FDA antibodies testing are positive? So what is this? This is latent syphilis. So you divide it into two types. So there is early latent syphilis. In that case, the patient has had a syphilis infection less than a year ago, so that is early latent syphilis. What about late latent syphilis? So anytime the patient has history of syphilis infection over a year ago, or the onset of infection, the time is not known, that is when it's classified as late latent syphilis. So it's important because the treatment for both is slightly different. So for early latent syphilis, the treatment is same as primary and secondary syphilis. So for all primary syphilises, secondary syphilises, and early latent syphilises, you do benzathine penicillin G IM single shot. But for late latent syphilis, you do IM penicillin single shot for 3 weeks. Okay, so one shot versus like one shot every 3 weeks for late latent syphilis. Okay, and then there is the last type. It's called tertiary syphilis. Can you give me the symptoms? So of course, anytime patient develops like meningitis from syphilis, okay, or they develop gammas, okay, or they have cardiovascular lesions, or they have what we call Tabes dorsalis lesions in the spine. So all of that classifies as tertiary syphilis. And diagnostic criteria, same thing. If it's neurosyphilis, then you'll also have to check the CSF for VDRL. And also it's very important to do HIV testing in all patients with syphilis. What if a patient who had syphilis when they were young and decades later they develop like an ataxia with Romberg sign and severe pain in the legs and trunk and impaired deep and proprioceptive sensation, and they also have agile Robertson pupil, so pupils that accommodate but do not react to light. So their accommodation reflex is fine, but the pupils are simply unresponsive to the light, okay? And they can also have paraparesis with leg reflexia, sphincter dysfunction, and Charcot joints. So what is this? This is called Tabes dorsalis, and it presents usually decades after the initial syphilis infection, and it classifies it as tertiary syphilis. So how do you diagnose that? CSF analysis is important. CSF will show reactive VDRL and FDA antibodies, okay, with mild chronic pleocytosis. And then you can also get MRI to rule out other causes of bilateral deep proprioceptive sensation loss and Romberg sign, okay? Now, what if you give a patient penicillin and for their syphilis, and within 24 hours of giving them penicillin, they develop fever, chills, myalgia, headache, and sometimes even transient worsening of the lesions of syphilis. So what is this? This is not an allergic reaction. This is called Jarisch-Herxheimer. So basically, the bacteria are dying and they're releasing all these inflammatory markers. Okay, severe manifestations like hypotension, exacerbation of rash, or sometimes in pregnancy, fetal distress. Can also happen. And how do you treat it? It's mainly supportive. Since it's not an allergic reaction, there is no role for antihistamines. Okay, so you try acetaminophen or NSAIDs. Okay, and then this should not delay or preclude syphilis therapy. So if the patient needs like more than one shot, you make sure that they get all their penicillin shots. Okay, now what if the patient is having a penicillin allergy, or they have like a history of a true penicillin allergy? So what are some alternatives? So you can do doxycycline for 14 days in early syphilis. So we're talking primary, secondary, or early latent. Okay, or 20 days of doxycycline in late latent syphilis. So this is the preferred alternative. Keep in mind that we don't use tetracycline. I mean, we can, but it's less preferred due to GI side effects and dosing frequency, because you have to take it 4 times daily versus doxycycline. You have to take it 100 mg orally twice daily. Okay, and then ceftriaxone, 1 to 2 grams daily for 10 to 14 days can be used for neurosyphilis or like neurosyphilitic meningitis, okay, because it has CSF penetration. So if a patient has his history of penicillin allergy, alternative agent is ceftriaxone. The risk of cross reactivity is very low, and this is only for neurosyphilis, okay, not for the other types. For the other types, like I said, doxycycline is number 1. Okay, if the patient has contraindications to both penicillin and doxycycline, then also you can use ceftriaxone. Okay, and then what about pregnant women? So if a patient who's pregnant and they develop syphilis, penicillin is the only recommended therapy. Why? Because doxycycline is notoriously teratogenic. Okay, and then if they're allergic, you just simply have to do desensitization with like smaller doses of penicillin. Okay, by the way, if you knew all of this already, I think you're gonna do pretty well on the exam. But if you were not able to answer most of these, or you're feeling a little doubtful about your preparation, I suggest quickly going through all the board review episodes. But I'm guessing there is not enough time because we're in the middle of August, right? So then I suggest just cramming the notes like med school style, like from cover to cover. Cram every single concept and every single number. So I will paste the link to the notes in the description, and I highly recommend that you brush up on those before you head for the exam, especially if you're not able to answer most of these things we just discussed. Okay, moving on. A patient presents with a symptomatic kidney stone. When do we do medical management only? So for all kidney stones that are uncomplicated and their size is less than 10 millimeters and they're in the ureter, we do medical management only. Okay, so medical management with hydration, pain control, and tamsulosin. Okay, when do we consult urology? So anytime a stone is over 10 millimeters, patient needs urology intervention. Okay, or anytime the stone has a complication, so look for AKI, okay, complete obstruction, or urosepsis. So in all of these cases, you have to consult urology. Okay, also if the size is over 15 millimeters, you still consult urology, but they will probably need endoscopic fragmentation. Okay, and then for all stones that are over 30 millimeters in size, they will most likely need percutaneous nephrolithotomy, so in order to take that stone out. Okay, and then lastly, if you put a patient on medical management and you send them home and they come back after 4 weeks with persistent pain, and their stones are refractory to medical management, then also you should consult urology for surgical management, okay? Patient comes with chronic shortness of breath, you get their pulmonary function tests. So what will be the pulmonary function tests in COPD? So patient will have low FEV1 over FVC ratio, so less than 80%, okay? Their FVC itself, the FVC number can be normal, or in some cases it can be increased, okay? Same with TLC, or total lung capacity, okay? And then what about diffusion lung capacity, or DLCO? So it should be normal in early COPD, but sometimes in late COPD it can be low, okay? What about asthma? So FEV1 over FVC ratio will be low in asthma as well. So both in asthma and COPD, FEV1 over FVC ratio will be low, okay? And then TLC can be normal or high. Same thing with FVC. FVC can be normal or high, okay? And DLCO is usually normal, okay? So these are obstructive diseases. Their hallmark is that the FEV1 or FVC ratio is low, and then less than 80% to be specific, okay? What about restrictive lung diseases? So in interstitial lung diseases, like, systemic sclerosis and all that jazz, FEV1 or FVC ratio will be normal, okay? Extremely important. And then FVC will be decreased, okay? Or TLC will be decreased. So if you see in question stem that FEV1 or FVC is normal, but FVC is decreased or TLCO is decreased, you think of restrictive lung diseases, okay? So what do we do next? We look at DLCO, or diffusion lung capacity. So that is going to tell us if the problem is inside the lung parenchyma or outside, okay? So if it's like an intrinsic problem, or if it's like a chest wall problem. So what if DLCO is decreased? It means that the lung diffusion capacity is low, and there is something wrong with the lung parenchyma, okay? So that means that there's an intrinsic cause. So look for pulmonary fibrosis, okay, or systemic sclerosis, okay? What about if patient's FEV1 or FVC is normal, TLC is decreased, FVC is decreased, but DLCO is normal? So that is also a restrictive lung disease, but this time this is a chest wall problem, okay? So look for, something that's compressing the chest. So maybe obesity, kyphoscoliosis, kyphosis, or ankylosing spondylitis, or even like a neuromuscular problem, so myasthenia gravis, or like GBS even. So less than 20% is highly specific for neuromuscular disorders, okay? Also, how will pulmonary function test look like in pulmonary arterial hypertension? So if a patient has isolated pulmonary hypertension and they don't have coexisting lung issues, the spirometry will be perfect except DLCO. So if you see that the spirometry is absolutely fine except DLCO that is low, think of pulmonary hypertension, okay? And then lastly, what are some causes that can cause high DLCO? So you have polycythemia, okay, intrapulmonary hemorrhages, so things like smoked fentanyl or good posture syndrome. Intrapulmonary hemorrhages are very fatal, so you'll have to do bronchoscopy, and in most cases you'll end up intubating the patient, okay? And polycythemia makes sense because if there is too much blood, the diffusion capacity across the lung will be increased by default, and by too much blood I mean too much hemoglobin, okay? And then lastly, left to right shunt. So if the patient has like an ASD or a VSD, they will have high diffusion lung capacity, okay? A patient presents to you with fatigue, muscle weakness that worsens later in the day, and they also have trouble keeping their eyes open. So what is this? This is myasthenia gravis. So what is the test of choice to confirm myasthenia gravis? As acetylcholine receptor antibody, okay? So if the acetylcholine receptor antibody is positive, myasthenia is confirmed, but you also need 2 more tests in all myasthenia patients to rule out some other diseases. So what are those? Number 1, you need a CT chest. So anytime a patient presents with myasthenia for the first time, you check every one of those patients for thymoma, okay? And then also you need to get TSH. Why? Because myasthenia gravis is associated with autoimmune thyroid diseases, okay? For patients who already have a diagnosis of myasthenia and they present later with rapidly progressive disease or treatment refractory myasthenia, then you should also repeat imaging to make sure they don't have thymoma now, okay? And then what if you get the acetylcholine receptor antibody? Remember, we just talked about it, and it's negative, but the clinical suspicion is high. What can you do? You can get EMG or nerve conduction studies to confirm, okay? Also, older like clinical bedside tests like ice pack tests and adrophonium testing, they're all outdated and they're not recommended due to extremely high false positive rates. Now, what is the treatment for myasthenia gravis? So for mild to moderate myasthenia gravis, the treatment is outpatient and first line is pyridostigmine, okay? If that's not effective, you can add immunosuppressants like prednisone, okay, steroids of course, and then azathioprine, mycophenolate, or cyclosporine. What if the patient presents with a myasthenic crisis? So how do you define myasthenic crisis? Anytime patient has acute worsening of muscle weakness, okay, or anytime patient has a respiratory involvement. So if they're hypoventilating or if they're struggling to take a breath, or if like their airways compromised, that classifies as myasthenic crisis. So what's the treatment for that? First line is plasmapheresis or IVIG and steroids, okay? Plasmapheresis kind of removes antibodies and IVIG like inactivates them. And also you need to keep checking the negative inspiratory force or NIF, okay? So keep checking that regularly. If it goes over negative 40, then you need to either do like non-invasive ventilation, or you might end up doing full-fledged intubation and ventilation, okay? Also, of course, if the patient is not responding to IVIG/steroids, you need to get them to ICU and you will have to start rituximab, okay? And you might end up trialing other immunosuppressive drugs as well, okay? Patient presents to you, they're a heavy smoker, okay? They're thinking about quitting, but they're not wanting to quit right away. So what are your options? So the best option is start them on varenicline, nicotine gum, and patches, all three together, okay? And patient doesn't have to like quit smoking cold turkey. You can start all these three while patient keeps smoking, okay? And then what is the contraindication for varenicline? So CKD stage 3, okay? And then what are some side effects of varenicline? So it can cause really bad vivid dreams. It can also cause constipation, nausea, vomiting, and insomnia, okay? Now, what if you are working in the ICU and you have an intubated patient and you're doing a daily spontaneous breathing trial and SBT? So what is the criteria to pass SBT? So there are a few things, okay? So patient has to be hemodynamically stable, okay? Their oxygen saturation has to be over 90%, or put another way, their PO2 on ABGs has to be over 60 millimeters of mercury, okay? They have to protect their airways, and they have to not have excessive airway secretions, okay? They also have to have like pH of over 7.25, which means that if they're in respiratory acidosis, do not extubate them, okay? And then also they also have to have RSBI less than 105. What is RSBI? Rapid shallow breathing index. So if their rapid shallow breathing index is more than 105, they shouldn't be extubated, okay? Because they're not ready to be weaned off yet, because they're basically breathing very rapidly and their breaths are very shallow, okay? And then they also have to have a GCS of over 10, okay? And then they have to be able to lift their head for more than 15 seconds, okay? And then lastly, they have to be able to initiate their own breath. So if all of this is fulfilled, then you can extubate the patient because they have passed their SBT. But if either of these conditions is not met, then you shouldn't extubate them, okay? Patient comes with a subacute cough, and they have these big like circle-like lesions on their like extensor surfaces of their limbs, so erythema nodosum. And on chest X-ray, they have bilateral hilar lymphadenopathy, so typical sarcoidosis, right? But they also have polyarthralgias or periarthritis, but the arthralgias involve ankles, okay? So we have erythema nodosum, bilateral hilar lymphadenopathy, and polyarthralgia involving the ankle. So what is this? Löfgren syndrome. So it's a variant of sarcoidosis. It's typically benign, and then diagnosis is clinical. So basically the triage you're looking for is erythema nodosum, bilateral hilar lymphadenopathy, and polyarthralgia. And then treatment is supportive as the disease is benign and self-limited, so use NSAIDs, okay? But if the patient's symptoms persist or they're very severe, or like if the arthritis is disabling, in those cases you can also do short courses of steroids. So that is one flavor of sarcoidosis that is very important for the exam, okay? A patient has elevated liver enzymes or maybe cirrhosis. They also have like Parkinsonism like features, like with tremors, and they might have ataxia, or they can have psychiatric symptoms, so psychosis or depression. So we have liver injury, we have Parkinsonism symptoms, and we have neuropsychiatric symptoms. And then they also have gray rings in their eyes on slit lamp. So what is this? Wilson's disease, okay? So basically copper overload. So how will you diagnose it? You'll check ceruloplasmin. It will be low, okay? And then 24-hour urine copper will be high. And then slit lamp will of course show the gray rings, and those are called Kaiser-Fleischer rings, okay? And then if the diagnosis is still not clear, you can always get a liver biopsy, okay? And then gold standard for testing is genetic testing. So if nothing is working, you can get them genetically tested for Wilson's disease. And then treatment is with a copper chelator like D-penicillamine, or second line would be zinc. Okay, so that's Wilson's disease. Look for elevated liver enzymes or cirrhosis and Parkinsonism with like neuropsychiatric symptoms. What if a patient comes in with like an acute heart failure problem, and you keep giving them diuretics, but they're not working, and you give them digoxin, they're still not working? So what is the next step? You try dobutamine or vasopressors, okay? But here's the kick. You only try dobutamine if there is no hypotension. So if a patient has like refractory heart failure, but they also have hypotension, then don't be putting them on dobutamine. Dobutamine is only for patients with refractory heart failure, and they're normotensive, okay? What's another medication that you can use? Milrinone, okay? So all patients with severe refractory heart failure that who have low cardiac output and they're unresponsive to standard therapy, you can try Milrinone, okay? It can also be used in select cases of cardiogenic shock and perioperative low cardiac output states, but honestly that is not that important for the exam. So if I were you, I would remember short-term intravenous treatment for acute decompensated heart failure in patients who have reduced cardiac output and they're requiring vasopressors. So look for that in the question stem, okay? Since we're on the subject, let's say that we have maxed out all the diuretics, we have maxed out digoxin, we have maxed out dobutamine and Milrinone. So what's the next step? Cardiac transplant. But of course, that's not the ideal. I mean, that's the ideal scenario, but not not practical often in real life. So what can we do? So we can either do like an intra-aortic balloon pump. So cardiogenic shock, especially when associated with acute MI, that is unresponsive to pharmacologic therapy, intra-aortic balloon pump is indicated, okay? And then we do like like an LVAD or like left ventricular assist device, and then the ultimate treatment would be like I said, cardiac transplant, or sometimes you can do ECMO as well. So to recap, mechanical options for severe refractory heart failure, for like the kind of patients who are on vasopressor and like they're very critical, we have intra-aortic balloon pump, especially in patients who have heart failure post MI, and we also have the option of left ventricular assist device, and then ultimately cardiac transplant. Okay, what if a patient presents with a thyroid nodule? So what are the next step in evaluation? So for all patients who present with a thyroid nodule, the first thing you're going to do is get a TSH, okay? And then the next thing you're going to do is get an ultrasound, okay? So if first scenario, so if TSH is normal or high and ultrasound is showing high risk features like irregular margins or microcalcifications or increased vascularity, or if the lesion is over 1 centimeter, if any of this is positive, the next step, you have to get a tissue diagnosis by doing like a fine needle aspiration, because all of these features are high risk for malignancy. Okay, if TSH is low and ultrasound does not show any high risk features, what's the next step? Radionuclide iodine scan. Okay, so now we're looking for hot versus cold nodule. So if the radionuclide scan shows like an increased uptake in one particular area of thyroid, it means that it's hyper functioning or hot nodule and it's benign. Okay, however, if the nodule is showing decreased uptake, then it's cold nodule and it's high risk for malignancy, and you need to get like an FNA. Okay, and this is one of those things where you have to look at the algorithm. So make sure to check out the notes in the description for the algorithm, okay, in the endocrinology #1 section. And then what are some features of nodules, thyroid nodules that are benign on ultrasound? So if a nodule is hyperechoic or partially or fully cystic, or if it's spongiform, it's more likely to be benign. Okay, and then lastly, what are some risk factors where if they're present, we have to get a tissue sample? So past history of thyroid cancer. Of course, if a patient has history of thyroid cancer previously and they present with a thyroid nodule, you can't just not do anything, so you go straight to FNA. Okay, and then if a patient has a first degree relative that has thyroid cancer, that's also a very worrisome for malignancy. Or if the patient had a childhood radiation exposure, like maybe they had some kind of cancer and they were given radiotherapy. Okay, or if a thyroid nodule starts growing very rapidly, like if it doubles in size in less than 3 months or something, that's an indication for going straight to FNA. And then lastly, cervical lymphadenopathy. Okay, anytime you have a thyroid nodule with cervical lymphadenopathy, you have to get tissue diagnosis with FNA. Okay, make sure to check the algorithm. And then what if a patient has severe pain with bowel movement in their perianal or like rectal area, and they also have a lot of perianal itching, and on toilet paper they get bright red blood? So what is this? Anal fissure. Okay, so whenever you get anal fissure, you have to rule out some causes that might be responsible. The most important for the board is Crohn's disease. Okay, so Crohn's disease can cause any GI problem from starting from the mouth all the way to the anus. So it can cause recurrent aphthous ulcers, okay, or it can cause anal fissure. So it's not like just a disease of your gut or something. It can also cause problems with biliary system, or like even it can cause like pancreatitis. So just don't think that Crohn's disease is only limited to the gut. Okay, what else can cause anal fissures? So long-standing constipation, okay, anal sex, any kind of anal trauma, like maybe surgery, okay, and then sometimes cancer too. So if they have cancer of the rectum, that can cause anal fissures too. And then infiltrative diseases, so sarcoidosis, okay, or STDs, so HIV, syphilis, chlamydia. So all of these can cause anal fissures, so make sure to evaluate for all of these. Okay, what if a patient who's on warfarin has an asymptomatic INR elevation, like they don't have any bleeding or anything, they're totally asymptomatic, and you check their INR and INR is elevated. So how do you manage? Depends on the INR. Okay, so if INR is less than 10 and patient has no bleeding whatsoever, what all you have to do is just hold warfarin. Okay, so if INR less than 10 and no bleeding, just hold warfarin. What if INR is over 10 and no bleeding? So in that case, you hold warfarin, but you also give oral vitamin K for reversal. Okay, and then what if a patient who's on warfarin and they have elevated INR and they start bleeding? So a bleeding patient on warfarin with INR, what's the treatment? So you do IV vitamin K instead of oral, and you also give 4-factor prothrombin complex concentrate. If that's not available, then you do fresh frozen plasma. But first line is IV vitamin K and 4-factor prothrombin complex concentrate. If the patient who's on warfarin has bleeding and their INR is fine, you don't have to really do anything. Just monitor the INR closely, and then of course hold the warfarin. Okay. What if you have an intubated patient and they have like unexplained tachypnea, increased work of breathing, dyspnea, and there is patient ventilator asynchrony, very important. Okay, and then they might also have pulsus paradoxus and hypotension and overall hemodynamic instability. So patient on ventilator and of course sedated and intubated, they have sudden onset increased work of breathing, accessory muscle use, pulsus paradoxus, hypotension, but most importantly, patient ventilator asynchrony. So what is this? Auto PEEP, okay, or breathtaking. So how to diagnose? So the word or the phrase you're looking for is persistent expiratory flow at end exhalation ventilator waveform. So at the end of their exhalation, they will still have persistent expiratory flow. This will be the waveform showing on the ventilator. I have put a picture in the notes, so make sure to check out the video ICU number 1. Okay, so what's the gold standard for diagnosis? So end expiratory occlusion maneuver. So if the end expiratory occlusion maneuver shows pressure of more than 0, auto PEEP is confirmed. Okay, and then treatment for auto PEEP. So you have to reduce minute ventilation. So minute ventilation is a product of respiratory rate and tidal volume. So lower the respiratory rate and lower the tidal volume to allow more time for exhalation. Okay, and this will increase expiratory time as well. And then what can happen with untreated auto PEEP? So we already talked about hemodynamic compromise, including hypotension. It can also lead to cardiac arrest and reduce cardiac output. And in some cases, you might have to apply external PEEP, so like low-level external PEEP. Okay, so that's auto PEEP for you, very important. And again, all of this is coming from the previous like episodes and like notes. So definitely check out the description for links to notes, and I will see you in the next one. Okay.